Hello and welcome to this week's seminar, which is a mixed bag of post-traumatic presentations and whether or not it should have been x-rayed prior to referral to you, or alternatively, if the patient came directly to you, should you request an x-ray before beginning treatment. The recommendations are based on well-researched and established protocols, which will be discussed at the end of the webinar. The scenario will be presented with all the findings you require to make a decision, not about the diagnosis, but about a need for an x-ray. I will leave each slide running for a couple of minutes for you to come to a conclusion and then give the answer and the rationale. As the webinar is entirely a quiz, the usual quizzes will be omitted this week. A quick word about movement diagrams for spinal problems. First, not everybody uses them, and second, the lines are different for different people. I will use the left diagram, and it is a notation that will be used throughout this webinar. Imagine looking down on somebody. The arrows point in the direction that the head is moving. Rotation is indicated by diagonal arrows, which are originally curved line as in the second diagram, and is often still seen as such. Some areas, notably the USA, use a horizontal line for rotation of the diagonals and side flexion, but this makes less sense to me, so it will not be used. The range of motion is marked by a cross or bar on the line of the limited movement at the appropriate point on the line, with a plus or plus, however you want, for the degree of pain involved. Additions can include the end fill written by the line, whether it is active or passive movements that are being described, and any other notation you feel is necessary. A young middle-aged man inverted his ankle and attended the ER. It was decided there that an x-ray was not necessary and to treat him with partial weight bearing on crutches, compression bandages and anti-inflammatories. He was told to rest it, use ice with elevation and come to PT. There was moderate bruising around the lateral ankle, and plantar flexion and inversion were painful. The range of movement was painful enough to prevent stress testing of the lateral ligament, but the ligament was tender. Based on these findings, should an x-ray have been taken before starting treatment, and why? If so, and why not, if not? The Ottawa foot and ankle rules is the most useful and accurate protocol for determining if an x-ray is required or not. It is of course designed for the ER, but there is absolutely no reason why it shouldn't be used by the PT. It does not diagnose a fracture, but it does say that there is sufficient chance that a fracture exists that an x-ray is necessary. In this particular case, there is nothing to suggest that an X-ray is negative, so quite correctly, no X-ray was taken. A young woman adducted her knee playing soccer, really football, complains of lateral knee pain, and she had to limp off the field and stop playing. You have treated her before for an ankle injury, so she came to see you directly. Objectively, you find moderate swelling and slight bruising over the lateral knee. The range of motion is moderately limited, and various stress testing of the lateral ligament was painful, and the ligament tender on palpation, as was the fibular head. Isometric knee flexion was painful, but the biceps tendon was not tender. Does it need an X-ray? If yes, why? If not, why not? The Ottawa knee rules has almost 100% sensitivity, but only about 50% specificity. So it's not great for making an accurate diagnosis or even including fractures, but it is excellent at excluding them. That is, if all the rules are obeyed, the chances of a fracture being present are extremely small and no X-ray is required. But if even one of the rules is breached, then an X-ray is necessary. In this case, the presence of tenderness of the fibular head breaches the rules, so an X-ray should be taken. Other reasons, but not part of the rules, to suspect a fracture is the bruising and the pain on isometric testing of knee flexion, but the absence of tenderness of the tendons. The mechanism behind this is that the contraction of the biceps will pull on the fibula and cause pain if it is fractured. A very similar case to the last one, but is your response the same or different? Similar, but not the same. There is no tenderness over the fibular head. The various stress test is positive and the tendon is tender, and there is no pain on isometric contraction. An X-ray according to the rules is unnecessary unless you find something else in the exam that concerns you. An older man in a rear ender complains of unilateral neck pain and upper trapezius pain. There are no neurological signs or symptoms, and the range of motion is slight flexion, moderate rotation and side flexion, and a fair chunk of extension loss with pain on 4 of the 6 movements. This pattern is very typical of traumatic arthritis. He is 66 years old, so he should have had an X-ray, even though there is not much in the history or objective exams to suggest a fracture. At this age, there is likely to be some osteoporosis, so less force is required to fracture the bone, and often the pain intensity and reaction to the injury are not as extreme as is often the case with a healthy tissue fracture. This case is a little different and more complex. This lady attended ER complaining of knee pain after it struck the seat in front of her in a head-on collision. After the knee was examined, she said that she had slight neck pain, and X-rays were done and came out negative for both the neck and the knee. She was sent to PT for treatment for her knee, but the PT examined her neck, finding severe loss of right rotation, right side flexion and extension. He then carried out a sharp Purser test, which was positive for translation with no neurological symptoms. What is going on? The PT sent the patient back to the ER detailing his findings and asking for a flexion extension X-ray to be done. It actually showed a hangman's fracture, a traumatic spondylolisthesis of C2 on 3, seen when in flexion the body of C2 moved forwards on 3. The images are not from the case, but they do illustrate the fracture. The sharp Purser test was done as a routine on the belief that the X-ray result was a true negative, and presumably the reason for positive translation was because the body of C2 slipped forward during the flexion phase and was pushed back during the second phase of the test. Interestingly enough, the chance of a spinal cord compression with this fracture are low because the slip actually opens the spinal canal. So it is important that the true positive for the sharp Purser test is a feeling of translation and not, as often quoted, the decrease of spinal cord symptoms. There was a good reason to suspect the false negative report of the X-ray due to the patient's age and combined with a severe loss of range, especially as there was not much pain involved, a fairly good sign of a pathological fracture. So this is a case of the X-ray being correctly ordered but also believed when it should not have been, and followed up by a CT scan. The Ottawa and Canadian C-spine rules are used worldwide. The intent of these rules is to reduce the number of X-rays used in emergency rooms. So they have to be good at excluding fractures, which means high sensitivity, which they have. The sensitivity for all these tests is in the high 90s, so not too many fractures will slip by. On the other hand, the specificity is very modest, doing worse than 50%. So there will still be a lot taken that will prove negative, but far less than had been prior to the rules being put in place. While designed for the ER, they are perfectly usable by PTs days and weeks after the injury before referring to the physician for an X-ray that should have been taken, but for various reasons wasn't. I am sure that in combination with a good subjective exam with questions such as how bad and how sudden was the pain at the time of the injury, the specificity can be increased and lower the risk of doing more damage with a rigorous objective examination. In addition to these rules, there are the Amsterdam rules for wrist fractures and the elbow extension rules for elbow fractures, but these are topics for a future webinar. I hope you enjoyed this seminar, and always stay safe and healthy. Take care. Bye.